Thank you so much for having me. It's a very much an honor to be joining this morning. It is very early in the United States, but I am happy to be with you all. So again, my name is Connor Ziegler, and I'm an orthopedic surgeon in Massachusetts. I live about 2 hours west of Boston. So just some background. So we know there are many risk factors for ACL graft failure. In the literature, the graft failure rate after primary ACL reconstruction ranges from 6 to 9%. This can be due to technical errors, graft factors, malalignment as we discussed, recurvatum deformity, knee hyperlaxity or global hyperlaxity, unaddressed injuries at the time of the primary ACL reconstruction, tibial slope, particularly posterior tibial slope, the age of the patient at the time of their ACL tear. Certainly psychosocial factors are influenced as well, and then inadequate rehabilitation. So why does it matter? Well, first and foremost, patient well-being. Outcomes, as we know, are typically not as good with revision surgery, so we need to try to get it right the first time. Identifying modifiable risk factors is very much vital to success, and we're able to better counsel our high-risk patients when we have a better knowledge of all the risk factors that may be involved. So what do we know? Well, we discussed tibial slope, and there have been numerous studies that have linked increased posterior tibial slope to ACL graft failure. There's a significant association with increased tibial slope and revision ACL reconstruction. And there was some good biomechanical data that has come out recently showing a linear increase on graft strain with axial loading as posterior tibial slope increases. Slope-reducing osteotomies are reported to be protective of the ACL graft. And what is the magic number with posterior tibial slope? Well, we certainly know that 12 degrees carries a much increased risk of graft failure. And how about hyperlaxity? Well, this is definitely something we need to consider in our patients. Hypermobile patients, this is a study from Dr. Chris Larson in Minnesota. Hypermobile patients have a significantly increased ACL graft failure rate of greater than 24% in his study. Overall, ACL re-injury rate, and that could be on the same side or the contralateral ACL, was 34% at a mean 6-year follow-up. Physiological knee hyperextension is reported to be an independent risk factor for ACL graft failure. And high-grade preoperative knee laxity is another reported risk factor. So these are all things we need to consider. And surgical factors such as tunnel position are also very important. We know that there's a common cause of both intraoperative complications and graft failure with tunnel malposition, and this is particularly so with femoral tunnel position. And we've had many studies over the last 15 years with a renewed focus on anatomic tunnel placement. What about other injuries? Well, you need to look for them, certainly. These include ramp lesions or posterior-medial meniscocapsular separations, which occur in 13% of ACL tears in some reports. Posterior horn meniscal root tears, particularly the lateral side. And presence of meniscal lesions we know is correlated with lower patient-reported outcomes after revision ACL reconstruction. So not addressing these other injuries places the ACL graft at increased risk. And what about graft choice? Well, we know that there's a higher failure rate reported with allograft in younger patients. There are some studies that show equivalency, but there's also studies that show higher failure rate with hamstring in younger patients as well compared to BTB. Obviously, open physes influence what we use for graft choice, and good outcomes can be achieved with different autograft options. Graft diameter is a factor, particularly grafts less than 8 millimeters. And certainly graft fixation. However, we have many fixation options these days. And as Conrad had alluded to, this is a recent study that I was involved in with Dr. LaPrade on. This was published in the Journal of Arthroscopy in January this year. And this was a study that I think really highlighted a lot of the risk factors and kind of delved into it a little bit more, particularly in tunnel malposition. So this was a retrospective cross-sectional comparison of patients who had presented for primary ACL tear or ACL graft failure in a single surgeon's practice over a 2-year period. There were 109 primary ACL patients with at least 1 year follow-up and 90 revision ACL patients. We collected all the demographic, examination, operative, radiographic, and advanced imaging data on all patients. Tunnel osteolysis was assessed on all revision patients preoperatively using CT imaging. And for tunnel position analysis, we performed 3D CT reformatted images, so reconstructions to really assess fully three-dimensionally the tunnel position on both the femur and the tibia. And so what were the results? Well, 87% of revision ACL patients in this practice underwent a two-stage reconstruction. And that would involve a first stage, typically bone grafting, particularly if there was evidence of osteolysis or tunnel overlap. 96% of patients in the primary group had a BTB graft, and that was either autograft or allograft, with the vast majority being autograft. 82% of both primary and revision ACL reconstructions were performed using BTB autograft. There were no reported graft failures in the primary group at a minimum 1-year follow-up. 28% of revision ACL patients from outside centers had primary ACL reconstructions performed using allograft tendon, and 62% of these reconstructions were used as soft tissue graft. And these again are from primary ACL reconstructions performed at outside centers, but were involved in the revision group in this study. So compared to the primary ACL group, the revision ACL group had significantly increased Batten score, and that was 4 versus 0, greater side-to-side difference in quadriceps circumference, and what I thought was pretty notable was an increased family history of ACL tear. That was 48% versus 16%. When comparing the MRI data compared to the primary group, the revision group had significantly increased posterior tibial slope and increased anterolateral and anteromedial tibial subluxation. These are a couple figures from the study highlighting the 3D reformatted images, and this is how we looked at tunnel position. So we looked at tunnel position on the tibia from anterior to posterior and from medial to lateral. And in alignment with the original Bernard and Hurdle study, we looked at the deep shallow position and the high-low position relative to Blumenstadt's line and the anterior and posterior aspect of the femoral condyle. And that's basically with the looking right directly into the notch from a sagittal view. So with our CT scan data, 78% of patients in the revision group had tunnel malposition in 2 of the 4 positions. So again, 2 positions were measured on the tibia and 2 on the femur, so 4 total. 22% of patients had combined femoral malposition in the deep shallow and high-low positions. And transtibial drilling accounted for malposition in 3 of the 4 positions, and this represented over 29% of ACL graft failure patients in this study. Another point I wanted to address was meniscus tears, and there was a high prevalence of lateral meniscal root tears in both the primary and revision ACL reconstruction groups. And repairs were performed in almost 29% in the revision group compared to almost 15% in the primary group. 94% of patients in the primary group had meniscus tear at the time of surgery. And these data suggest the importance of thoroughly evaluating for meniscus tears, including root tears, at the time of ACL reconstruction. So in conclusions of this study, again, the revision ACL group had significantly increased posterior tibial slope and tibial subluxation both anteromedially and anterolaterally compared to the primary ACL group. The revision group also had significantly increased Batten score, greater side-to-side difference in quadriceps circumference compared to the primary group. There was a positive family history of ACL tear that was significantly more likely in the revision group. And again, that was 48% versus 16%. Another known risk factor for ACL graft failure supported by this study is certainly tunnel malposition. Thank you.